Hello, sir. Good evening. I'm Dr. Sangam Pal. I'm be describing a surgery done on 1 day old baby who has unfortunately had bilateral choanal atresia. So I'll be sharing my video. So, sir, this is endoscopy. So, sir, this is very uncommon anomaly occurring in 800 to 5,000 to 8,000. So this is mucus present inside the nose. So uh, the obstruction was visible nicely. It occurs in 5,000 to 8,000 birth. And first corrective procedure was attempted by Emmott in 1851, and unilateral choanal atresia is more common than bilateral, and it is associated with other genetic malformation in 20 to 50% of the patients. So I'll just forward. So this is the blind end visible. This is the blind end visible. So actually to diagnose, uh, we need not take patient under GA. This was just before surgery. Uh, to diagnose, we just need to pass a infant feeding tube through the nose, and if it doesn't, we are not able to pass, we can label this as choanal atresia, and we can do flexible scopy. I had done flexible scopy, but then image was not that clear, so I didn't include in this study. So this is CT scan. Most of the choanal atresia is mixed variety, that is bony and as well as membranous type. It presents as medical emergency at birth, airway obstruction, stridor, and cyanosis while crying are usual presentation. Immediate management by oral airway, McGowan nipple, or intubation may be needed prior to definitive procedure. This baby was intubated, as we can see. So this is membranous portion, and this was the bony portion. So this was the mixed variety. So I managed this case using endoscopic puncture dilatation method and with stenting. So this is the dilator which I used, made by Santosh Surgical. Courtesy, they manufactured this instrument in a day and delivered. So this is the smallest uh, puncture suction, which has olive tip, and there are suction present on the side, so it will suck the blood and mucus, and this is used for puncturing the stenosis, and later we can use the increasing in size for dilatation. So this procedure was done under general anesthesia. Nose was anesthetized using nose was anesthetized. Sorry, I'm not able to share. So this was done under general anesthesia, and nose was decongested using 0.05% xylometazoline in patty, and nasal cavity inspected with 2.7 millimeter endoscope, and secretion sucked out using ear suction. and smallest dilator used, and blunt and punctured using gentle force inferiorly and medially. So this is pressure is applied inferiorly and medially towards septum. This is inferior turbinate. This is septum. So one initial opening was made, and then later on this opening was dilated with uh, bigger dilator. So this is second one. So the only uh, thing, basic principle is कि both side should be dilated simultaneously, because if we dilate one side and then the second side, then what will happen, the septum will get shifted to opposite side. So first uh, this is the second dilator inserted in right nostril, and after inserting second dilator in right nostril, the left nostril was punctured with the first dilator. So that way, gradually, this is how the dilatation are being made. And it is attached to suction, so it is sucking any secretion or blood. Now, we have to keep that dilator in place and in right nostril and dilate the left nostril. So like this, both nostrils should be simultaneously dilated. Then we remove the second and we insert the third one. So serially both nostrils are dilated. And see, this uh, and after dilating both sides, the posterior part of septum is partly removed. So now this is after almost full dilatation. Using a 0-degree endoscope, we are able to see the opposite dilator as well as throat pack. Then the posterior part of septum is removed partly using ear curette. So ear curette and flap elevator are used to remove part of the septum posteriorly, part of the vomer bone, to make opening bigger. So after dilating the choana to the maximum limit, uh, we passed a 5 number red rubber catheter with the larger end inside through the nose and retrieved it through the mouth. from both nodes different red rubber catheter. So this is red rubber catheter we are inserting inside the nose with the larger end inside. So while inserting, the opposite nose should be stented with the dilator, because the moment we remove the dilator, it starts shrinking, the whole size starts becoming smaller. So after inserting inside the nose, and we require a little push using suction or some other instrument, this catheter is taken out. So this my suction is pushing inferiorly, so it will go, because so diameter is 5 millimeter and we want to put 3.5 millimeter endotracheal tube retrograde, and this endotracheal tube is cut in the center. I'll show. So this red rubber catheter is retrieved from mouth using cup forceps. So this is ear cup forceps, and which is used to cup or crocodile forceps is used to remove the endotracheal tube. This throat pack we have kept. Baby has 3.5 millimeter endotracheal tube. So now the same thing is done from the opposite nostril, and after removing the dilator, red rubber catheter is 5 number red rubber catheter is pushed on this side. So this 5 number red rubber catheter is being pushed, and then it is retrieved on from the mouth on right side. So this, so this is from right sides coming. So after removing both catheter out, we insert the endotracheal tube inside the catheter and suture it using 40 prolene. I'll show you how. That suturing part is not recorded, so I'll just stop. So this is how after removing red rubber catheter. So you can see this is the endotracheal tube. This is inserted inside the red rubber catheter and sutured using 40 prolene. So it will be so. So it is inserted inside and sutured, and now it is being pulled from the nose, and one person is pushing it, so that, and we have also applied xylocaine jelly, and see this is how it has been cut. The endotracheal tube is cut here. So this will go and snugly fit at the choana, and we will breathe on this from this side. So so this is the cut. It is 3.5 millimeter. This is the cut. This is the cut. So I was just seeing inside the nose whether. So after putting it inside, Yes, this is it. So this is going, I'm pushing, it is gone inside. So after this is endoscopy done through the stent, and we can see the throat back. And this is both endoscopy done through the both stents, and then the cut are the stent is cut to the appropriate. Now it is coming out from the nose, and is coming out through the nose, and then endoscopy done through the stent to see the whether it is in. So this is 70-degree scope. 70-degree scope is inserted to see the back end of coena, whether the stent is sitting properly. So this is 70-degree scope. No adenoid at birth. So this surgery was done on second day because it took 1 day to mobilize things. Thank you for watching, and special thanks to Nilesh Choradia sir, and Dr. Neetu madam. See, this is the stent which is visible in the coena from behind. And Dr. Sumit Warang, who was anesthetist to give anesthesia to this patient, and Santosh Surgical, special thanks for preparing this stent on very short notice. Thank you very much. So this is simple and easy procedure, can be done within 30 minutes and has fairly good result. Thank you very much.